Thanks very much for that, Sunit. It was a very interesting presentation. I think there's already one question that maybe we'll work in reverse. So we might start with you, Sunit, since we've got you online and unmuted. So it's from Helmi, who's online and said, "Hi, Dr. Sunit, great talk. Given that the colistin MIC breakpoint for Enterobacterialis and gram-negative bacilli is only meant for intermediate category as per the CLSI guidelines, what should the target be now for colistin?" So that's the first question, and I'll go on to the second question Helmi has after that first question.
We generally recommend a fixed target of approximately 50 milligram hour per liter without considering the MIC of the organism in the initial few days of treatment. Because MIC takes time, at least 7 days, because of the heteroresistance situation of colistin. It takes at least 7 days for the report to come. So we start with a fixed concentration target of 50 milligram hour per liter. Now, the targets which I have mentioned is appropriate for Pseudomonas and Acinetobacter. For Enterobacterials and gram-negative bacteria, other gram-negative bacteria, if we are going to use colistin, we cannot definitely increase the target more than 50 or at least more than 60, because if that increases the chance for acute kidney injury or neurotoxicity. So what we have at hand is, can we go lower than 50 or lower than 40? So of course, because these are intermediate resistance strains, it may be preferable to not go below 40, at least, milligram hour per liter. And the current recommendations are all for a target aiming 50 milligram hour per liter. And it's irrespective of the strains of bacteria. That's how we go about in India. Thanks for the question.
And the second part that Helmi had, because we've got some time, we finished early. So let's move on to that second part. Does this matter if we use it for an UTI where the drug is concentrated in the urine? So is that a clinical consideration when you look at target exposure?
Here in the hospital, we have a general consensus of still aiming for the target AUC of approximately 50 milligram per liter, even for treating UTI here. The reason being, in some cases, this organism may go into bloodstream, and therefore it's better to aim for always the higher targets, even for treating UTI patients. And our study was focused mainly on critically ill patients. So most of them were already having sepsis. And whether in what patients do we have to target these concentrations? I'm not really sure. Is that clear?
I had a follow-up question for you with regards to that, Sumit. In Australia, we don't use a lot of colistin, but when we do, we usually use the carbapenem backbone. So we use meropenem together with colistin. Do you think that would have any implications on what targets you commonly see or you use in your clinical practice?
So here in our study, in phase C of the study, we have found a great proportion of patients improved even when they did not achieve the target colistin AUC. Of around 55% of patients improve clinically within 7 days of treatment. And this is, we are talking mostly patients who were surgical, who underwent surgical interventions. And so they are kind of pure patients for infections. So they respond faster to antibiotic treatment in that way. So all these patients, here the protocol is, if you are giving colistin, we give meropenem along with it. So the proposed reason why this huge proportion of patients, even though they did not achieve colistin target, they attained clinical cure, maybe because of the synergism and the extent to which synergism happened and how that helps in patient improvement, we really do not know. And it's always safer to target higher AUC of cholesterol, like 50 milligram per liter, even if there is, even if the meropenem levels are adequate for those patients, because the infection may be in a deep-seated. So different factors may play a role in clinical outcome. One may be the deep-seated infections, so the site of infection. The other may be the SOFA score of the patient, baseline SOFA, which is relatively good. So multiple factors may be playing a role. So it's always safer to aim for a higher target of 50, because we really do not see a very high proportion of patients going for toxicity with these targets that way.
And that was where I was leading to. Do you do any beta-lactam therapeutic drug monitoring? Because you just said adequate exposure or adequate target for meropenem. Do you do any of that together with these patients at all?
Yes, in our institution we do meropenem. Meropenem, beta-lactam. This is the only one that we measure, unfortunately. Yeah, beta-lactam. Though we also do vancomycin, voriconazole, posaconazole, certain other antibacterials. So yes, we do meropenem, TDM.
Excellent. Thank you, Sumit. I don't know if there's any other questions here from either the panels. We've got a question here from an expert in his own right, so I think we'll get. Can I tell you and you repeat? You can come up here. No problem. We have Juan Pablo Ocada from Spain, Barcelona, and he has a lot of experience with colistin, so it'd be interesting to hear what he has to say.
Thank you. Thanks for your talk. Fantastic talk. I would like to ask you if you did any correlation between the steady state colistin concentration in plasma instead of the AUC over the MIC. If you correlated the steady state concentration of colistin in blood of patients with the renal failure.
Yes. So we have identified when the colistin concentrations go beyond. So in the presentation, I have shown that we identified a cutoff of around 66 milligram per liter of colistin AUC for predicting AKI in patients who have low genetic predisposition to colistin-induced AKI. And in patients who have high genetic predisposition to colistin-induced AKI, the cutoff is a little lower, like around 48 milligram per liter. Yes, of course, there is a correlation between colistin exposure and AKI.
Thank you.
Thanks.
Sumit, we might start asking questions to some of the other presenters. Thank you so much for staying. Please stay online. I've got actually a question while I scroll through some of these other ones. I've got one specifically for Alan, and it's not a question, it's more like a debating topic whereby I jotted this down, and I want your pros and cons for this, Alan. The statement is the next interventional work in therapeutic drug monitoring with model-informed precision dosing should entail machine learning to expedite identification of at-risk patients who are most likely to benefit from TDM interventions. Can you discuss this for us?
Sure. Well, I think we should do that because one reason would be there are a lot of patients at the ICU or any other department getting beta-lactam antibiotics. So it's, first of all, it's not feasible to do TDM or model-informed precision on all these patients. So you have to use your resources and available personnel to only do TDM in the patients which are at risk. That would be one practical pro for this approach. And what we also saw in the Dolphin trial is that the patients which are at less risk for target non-attainment won't even benefit for dose increasing if you do better exposure. So you should only focus on these patients which are at risk for target non-attainment, and these are usually patients with renal clearance and with other risk factors which could be identified by the physician, but some patients need more patient characteristics combined to be at risk, and that's, I think, pretty difficult at the time of initiating the antibiotic dosing. So the machine learning approach could be that we use algorithms which identify pretty specifically these specific patients. However, machine learning should be used, I think, in a setting where you use the clinical characteristics which are readily available. So looking at very complex biomarkers or a lot of patient characteristics combined won't be feasible in clinical practice, because often you don't know all these characteristics. So what we did in our approach is we did a lot of testing with all the variables we had, and the variables we did have a small increase in the prediction values. We excluded all these characteristics because, again, not all the patient markers or biomarkers are available at the time of initiation. Well, a con would be that using machine learning techniques could also lead to delay in the admission of the right dose. So you shouldn't have a tool, I think, where you should have a secondary program or something besides your electronic prescription system, where you first need to have the experience on using this technique and then start the initial dosing. Most dosing are sometimes also started at intensive care units where everything is started together. So different kind of interventions together, and using different and complex programs beside this wouldn't, I think, help the patient care.
It's very, very balanced, and I think a very realistic description of where we are currently. I know that AI and machine learning are touted as ways of expediting a lot of things, but like you said, there is a lot of complexity, particularly in these critically ill patients who come in with pathophysiology that is constantly changing within their first 24 to 48 hours of admission, which makes it very hard to actually even be able to detect those risk factors that maybe you've identified through big data, etc. So really, I thank you for that balanced view on that, Alan. And I think we have a question here from the audience. Juan Pablo here again.
Thank you. This is a question for Karen Deinzer. I would like to ask you your opinion about the possible differences that could be in the clinics between the immediate determination of antimicrobial concentrations in the serum in comparison with the current delay of receiving the results, like 12 hours later or 24 hours later after the extraction of the sample. This is my first question. If you think, or if you have demonstrated that there is a clinical impact of correcting the antimicrobial dose based on immediate results instead of results of blood taken like 24 hours ago.
Okay, thank you for this question. So actually we demonstrated that we can measure in an hour the result, but it was, since we did only an animal study, so it was not planned to have a correction of the therapy. So that was at the beginning. So our goal was to develop the device. So we would like to apply now in the second stage of this project, where we would like to also go actually, again, we would like to, it's a little bit also problematic in Germany to having this clinical trial. So we will, our second goal will be to take again animal studies, and there our aim will be to keep the concentration constant by frequently measurements, so that we will be capable of doing this. And after that, our goal will be to go to the patient. So this is still an ongoing work, but mainly actually we are limited there due to the at least on our clinical partner side. So they always say we need to first show that everything is fine, then we can go to the patients on that part.
Thank you. So your idea is doing a continuous monitorization and a continuous variation of the dose?
So it depends. I think it depends also on because we did not especially started this for sepsis. So our goal was just to measure and give you also maybe also at home possibilities to control your dosage. So I think for the normal healthy people, so it will be enough to see for the antibiotic the first clearance and the results behind. Then since your physiology does not change that much, but of course in the sepsis case, if you are in the ICU, everything can change, and there you need to most probably be more frequently to be measured to adapt. So if the patient gets more water content in this body, so everything could change, I believe.
Thank you. And in this sense, your idea is doing the determination in total blood, because this could be more rapid than in serum.
That we show that this is possible. So therefore, I think this could be a way. To be honest, we are as an engineer more interested in the challenges of the also non-invasive approaches. So therefore, we also move in this part. But we, as I said, since our assay is highly sensitive, so our results are, we can measure piperacillin tazobactam less than 1 nanogram per milliliter. So it's possible also to measure in the whole blood, since we can do this pre-dilution at the beginning. So there is no problems also measuring in whole blood.
We have another member of the audience, Marta Uldemotens, who's going to be asking a question as well. So,
hi, this is a question for Dr. Matthews, and again about colistin and meropenem. That's from the clinical part, and following what Os was asking about the TDM of meropenem, because, and of course I'm not the most experienced clinical in the room, but Dr. asking a question about what's the target of the meropenem concentration, because I assume that we're treating Pseudomonas and Acinetobacter with the drug resistant. So I would like to know what are the MICs we're talking about, and what will be your target, because from our clinical experience, we don't use colistin either, but when we use it, it's for multi-resistance, and we don't go up to more than 25 or 30 milligrams per liter because we worry about the toxicity. Could you comment about that, please?
I'm sorry, I couldn't hear you completely properly. So what I understood is you are asking about what were the MICs I was talking about.
Yeah.
And
for the brand?
yeah, so the MICs, there were around quarter patients had an MIC of around less than 0.25. A majority of patients had an MIC of less than 1, and few patients had an MIC of less than 2. And if the MIC is more than 2, we do not treat the patient with colistin. And for meropenem, we usually give continuous infusions. And usually these patients attain a concentration somewhere between 2 to 10 milligram per liter. Microgram per ml. The reason why we target a concentration of 2 to 10 for patients who are carbapenem resistant is if you target higher, there is a possibility for neurotoxicity. And if we target, if the concentrations achieved are much lower, then the synergistic effect, we are not very sure whether that will happen. So that's the reason why we still target steady state concentration of somewhere between 2 to 20 milligram per liter for meropenem. So in this, so the study was done in this setting. So most of the organisms were having a MIC of less than 1. Yes. Any other questions? I was not clear with the question. Sorry.
No, that's fine. That was my question, because not when my experience is with patients with deep-seated infections, like orthopedic, hyperciliary
So for-
infections and resistant, and we
So
normally target less than 30. But absolutely.
For lung infections, we definitely give inhalational colistin. So even if patient receive IV colistin sodium, we combine that with the inhalational colistins. So daily we give 1 million international units inhalation.
Thank you for that, Martha. I was actually going to follow up with Tan. I'm not sure if you saw those queries questions that have come online, Tan, regarding the elaborating on away from SOFA 1 in your presentation. Does that mean patients got worse? And also just more about the benefits of TDM by comparing those who were dead and alive using some simple tests instead of machine learning algorithms. I don't know if you've seen those comments at all, kind of on the chat. If you wanted to comment on those, that would be
Sure.
that would be.
Actually, I started also to answer them, but for that second question, I didn't have the time. So now I can do it like this. So the reason, maybe I can start why we choose SOFA 1. So the data was collected showing the SOFA 0 scores were some kind of not complete. So we decided to take the SOFA 1 as our healthy island or healthy place where we can say, okay, the patient is now almost completely recovered. So and that was, I think, a misunderstanding. So what we said actually, how fast this TDM group can travel to the SOFA 1, so which means actually it gets better. So for that, I don't want to get in that much in detail, but we use also single patients and also the cloud of the whole patients and its distance to this point. And actually, in both cases, we definitely saw in the first 10 days, we can clearly see difference between the TDM versus the non-TDM group. So that was a little bit surprising for us that the initial study just look at the day 1 of the study and the release of the patients, which we believe that this caused this conclusion that it's not that helping that much. So should I go also the second question also, or
if you believe that you've answered most of those, then I think we can leave it.
Actually, maybe just to say, so actually the more frequent approach I already answered. So this is really depends on the case. So if you are healthy, I don't think that you need to be that much frequently. But if you see, for example, I think as a clinician, if you see that the physiology of your patient is changing rapidly, so you will be very happy to see the result also very much faster than a day. I think this could be some kind of a, let's say, not maybe game changer, but would be an additional input to help the clinicians with their decisions.
Thank you very much, Dan.
You're welcome.
So it looks like since the questions were asked by Marta and Juan Pablo, there's some more questions that have been coming your way. So I think there's one that you might be typing an answer for Nadia, and I'll just read it out for the benefit of the audience. If you don't have therapeutic drug monitoring for colistin and your patient develops nephrotoxicity, how can you adjust the dose? I think that's the question that I can discern from what she's written. Do you have a comment for that?
Hi, Nadia. Thank you for the question. And There are different reasons for acute kidney injury in patients on colistin. So one reason can be severe hypoalbuminemia. So if the albumin is somewhat less than 2 gram per deciliter, that itself can predispose to colistin-induced nephrotoxicity. So correct severe hypoalbuminemia, that is one way of addressing it. Another reason is there are if the concomitant nephrotoxic drugs, if you add more and more concomitant nephrotoxic drugs, that causes that predispose to colistin-induced nephrotoxicity. So if you can reduce the number of nephrotoxic drugs you are administering along with colistin, that also helped in your situation when you don't have a TDM to do colistin. I see only these two as options. I will also go for guidelines suggesting how to adjust the dose based on the creatinine clearance. So these are the only few options left for you if you don't have a TDM in your institution. I hope I addressed that question.
I think you were quite clear. One of the follow-up questions that came about from your answer was the meropenem daily dose. Now, Tan has really asked a question that I'm interested in as well, which is based on your study, what is the usual meropenem daily dose that you use that has achieved this obviously is between 2 to 20 milligrams per liter is quite broad, and you do use continuous infusions, you said. So I suppose the question is, what is your daily 24-hour dose of meropenem that you administer as a continuous infusion to see these concentrations?
Yeah. So Dr. Menino is also well experienced with meropenem. Yeah, thanks for the question, Tan. So in our patients, we mostly see that if we give around 3 gram of meropenem, or 3 to 6 gram, that's a quite wide range, but yeah, only few percentage proportion of patients attain these concentrations. With 6 gram of meropenem daily as a continuous infusion, like 2 gram every 8 hours, because the stability is an issue if we give meropenem for a long period of time. So you have to divide it into multiple doses. So 2 gram every 8 hourly. The total of 6 gram will approximately achieve this target concentration for patients with normal renal function. If the renal function is poor, definitely you can reduce the duration of infusion and also the total dose.
No, you raised a very good point. Stability of meropenem, Sumit. So I'm glad you brought that up as well, given the fact that you really can't give it over 24 hours in a single bag. You have to have a bag change. Particularly, I can only imagine that Vellore also gets very warm there as well, and so the stability of meropenem would be even more questionable.
Yes.
Yes.
So yeah, the temperature definitely matters. The watt temperatures definitely matter. Yeah, if the higher the temperature, the stability is poor.
I think Alan has he's raised his hand, so be interested to hear what his comment.
Yeah, I would like to add to the discussion about the references for exposure of meropenem. In our hospital setting, we also use the exposure of 2 milligrams between 2 and 20, but only for the intermittent dosing regimens. For the continuous infusion, we want to achieve at least target level of above 8, which is translated from the Pseudomonas aeruginosa ECOG of 2, but not attaining 1 times above MIC, but 4 times above MIC for the continuous infusion. So the lower limit is much higher, and the upper limit we go up to 80. We don't see in this population serious adverse events. So I think you should, I don't know if in your hospital all the patients get continuous infusions, but in the continuous infusions you will see levels around at least above 10.
Thanks, Dr. Allen. Yeah. Thanks for the suggestion. Yes, continuous infusion generally achieves a level above 6 for generally for our patients. If we go by 2 gram TID as a 8-hour infusion. And thanks for the information that you can actually go something like up to 80, you said 80.
Yeah.
Okay, and patient did not develop any adverse events with that, is it?
Well, we don't have much patients on these continuing infusions of meropenem, but I think we accept exposure until levels up to 80 in our protocol for CDM of meropenem.
You meant trough concentration or the Cmax?
The trough, the continuous infusion concentration.
Yeah, yes. Okay. Thanks for the information. Thank you.
As a follow-up, Alan, and this might be just one of the last questions we have, is that it's interesting that you bring that up as a TDM approach in your hospital or in the healthcare setting that in the Netherlands. The reason I'm asking this question is because I noted in the Dolphin study there was a restrictive dosing strategy that was used to dosage adjust, and that might. Do you think that might have influenced target attainment, and could it have been a bit more, for want of a better term, aggressive in the dosing approach?
Sure, yeah, great question. I think we did have restrictions on dose maximum dose adjustment. However, I think that could, of course, influence the target attainment, but we didn't look at target attainment as primary outcome. We looked at clinical effects, clinical outcomes. But however, if you look closely to the data, having better exposure, and also in other trials like a target trial, won't lead to definitely better clinical outcome. So these exposure levels we had in the Dolphin trial, I don't think you can translate those levels directly to the clinical outcome itself. What we did saw is having early intervention, so having a good exposure in the first 24 hours of the treatment did have clinical effects or of effect on clinical outcomes. So eventually, I think we shouldn't focus only on the target attainment itself, but the initiation moment of the correct dosing in the critical hours of the infection itself. And one interesting topic also, which I answered in the questions, is in which patient should we use dose optimization? Well, if you look at the ICU patients, these patients have so many different interventions during their stay that effect of the treatment of antibiotics itself could be diluted or won't have as much effect as you want to, because they have other different problems during their stay that most often influence the clinical outcome, and also clinical outcomes like ICU length of stay. So it's pretty difficult to only say having better target attainment will lead to better clinical outcomes itself.
No, very, it's an important point. I think that from the Dolphin study, it was indicated that there could have been up to 36 hours before the intervention could have taken place. And I think people who are clinically minded here within our talk today, they would have emphasized that 36 hours, you're almost missing the boat completely of making any discernible difference to any outcome if you wait for that long for any intervention, even one that is perhaps a bit more nebulous, i.e. antibiotic dosage adjustments.
Yeah, sure. We wanted to emulate the current status of TDM. So usually you start the therapy and then you do a TDM within the first 48 hours. And in our case, so we had the first sampling between 24 and 36 hours, and then you did the intervention, of course. So a natural conclusion could be starting at a new trial where you dose more aggressive at the start of the therapy, so double dosing, then doing machine learning algorithm to choose the patients which are at risk of target non-attainment and continue monitoring these patients. But I think that's what we want to investigate in the coming few years. We are trying to set up these kind of trials. First, we do a clinical validation of the Batman algorithm. So a Batman trial started a few weeks ago, where we validate this approach prospectively without intervention. And then we will, I think, eventually go to settings where we use more aggressive dosing just at the first dosing moment.
All I can say is that your trials, Expat and Dolphin, have pioneered the way for the rest of us to think about how we can look at ways of conducting studies that are meaningful to clinicians, and not necessarily have the hard outcomes that we typically look for larger studies, given the fact that IC mortality in sepsis is multifactorial. And so we're trying to concentrate on one small area. So I think the work that you and your group have done is wonderful and something for us to build upon.
Yeah, thank you very much.
I'd like to conclude today's second session of the Worldwide Precision Dosing Seminar now. I'd like to thank Ken, Alan, Sumit for fantastic presentations and for answering all those questions that we had and facilitating a good discussion amongst the group, both online and in person, and for the questions from the floor as well. It was fantastic. I look forward to meeting all of you one day in person as well. So, and I've already met Sumit before, but I look forward to meeting Alan, Ken in due course. So thank you so much, and have a great day. Thank you.
Thank you very much. Likewise.
Thank you. Bye-bye.